Hello, my name's Adrian Wegg. I'm the chair of the ICS Scientific Committee, and this morning I had the privilege of chairing the session, the second State of the Art lecture in this year's annual scientific conference. And with me I have our speaker, Dr. Howard Goldman, who talked to us around the rather thorny issue of anticholinergic use and the associated risk of dementia. So, Howard, if I can ask, you very carefully dissected quite a complex relationship. Could you really give us the high points of that which you delivered to the audience today and some of the take-homes?
Sure. I think there's been a lot of press about anticholinergic drugs, particularly overactive bladder drugs, and a possible link with dementia. So we looked at first, is there a basis for this? And then we really looked at the data. And I think when you look at the data, there is an association that can be seen. It's not a strong risk such that you take anticholinergics and you get dementia. It's a very low, depending on the papers, even perhaps 1 in 137 per year of use. But certainly there are some concerns. However, I think we tried to make the point that there might be 1 or 2 medicines, oxybutynin immediate release, that is the most concerning. All things being equal, we might try to avoid anticholinergics and use some of the beta-3 agonists for this problem. However, I think we have to recognize that there are many places in the world, including where I am, that the coverage for some of those drugs is not quite good. And there are still a lot of the anticholinergics that do very well that have not been shown to have any impact on dementia. And so I think sort of the balanced message coming out was this is something to be aware of. I don't think we have to lose a tremendous amount of sleep over it, but be a little more selective in what we use. All things being equal, try a beta-3, but there's still anticholinergic drugs that can be used successfully, especially when you balance that with the problem that it's treating. So if you've got a patient who is floridly incontinent, has urgent incontinence and overactive bladder, and anticholinergic X does a great job with that, then you balance that, very, very small association of dementia with tremendous improvement in quality of life over time. And I think this is something that we shouldn't be scared about. We just have to know the facts and utilize these appropriately.
Yes, and you mentioned that many of the guidelines talk about older adults with cognitive impairment being at greater risk, but my understanding of the data is that that isn't very well supported. There are a couple of studies showing that adding anticholinergics to people with pre-existing cognitive impairment doesn't necessarily lead to a decrement in their cognition or delirium. So would you reassure individuals that, for older adults with dementia and symptomatic urgency incontinence, that anticholinergics are still a possibility, or would you veer away from those completely?
So all things being equal, if I could give them any medicine, I would probably preferentially use a beta agonist. However, if that's not available or it's expensive, I think there's still plenty of anticholinergics that I would not be too worried about. I probably would try to avoid immediate release oxybutynin, but for the rest of them, I probably would not have any problem with it. I would be more careful though, so I think I would follow these patients carefully, and if they were not responding to medicine, stop it as soon as possible.
Yeah, and that I think in the talk today you gave a very sensible, very practical, almost a mind map and thought tree for clinicians in the audience, and I think they should find that extremely useful. I think, as you also said, the fragmented nature of insurance approvals in the United States often makes second-line therapies much more unattainable, and the majority of prescribing is still, the generic oxybutynin, which we would try and avoid. And it needs a bit of society and persuasion around payers to come to Jesus around this.
Yes, I think there was one image we showed that showed by state the sort of move from anticholinergics to beta-3s, and the majority were still anticholinergics, even though the beta-3s were coming up. But I know just from talking to colleagues, they have sometimes used some of these statements. For instance, SUFU had a statement, some other societies had statements talking about preferentially, if you can, using beta-3, and they've sometimes used that to actually send that to insurance companies And in general, I've gotten a pretty positive response to that.
Well, that's at least heartening, because I know a lot of my colleagues in the States, and you know that there were really frustration of having medications which are inaccessible because of insurance companies.
Yes, there's nothing like trying to write for a beta-3, getting it switched to an anticholinergic, and then 6 weeks later getting a letter from the same insurance company that says, by the way, do you know that you're giving an anticholinergic that's on the Beers list, and you need to be cautious? I'm like, you're the one who forced us to do it.
Yes. Now, you also discussed the concept of protopathic bias, and I think in the audience, a couple of people put their hands up as knowing what that is. Could you reiterate exactly what all that's about and why that's a limitation in some of the studies?
Yeah, so that's very important. So protopathic bias implies that sometimes, and for using the example of OAB, one of the first signs of dementia may be lower urinary tract symptoms. I mean, there are a lot of things in that aging population, and a lot of things go along with some of these geriatric syndromes. And we know that patients with dementia often have a higher risk of OAB, et cetera, et cetera. And what may be happening is they may present to your office with urinary urgency, and otherwise everything looks fine. So you go ahead and prescribe anticholinergic X, and then 2 years later, they progress to significant dementia. And so somebody may come back and say, wow, you gave them the drug and that caused dementia. When in fact, what you were giving them the drug for, the urgency was actually the first symptom of that dementia. So that's protopathic bias. And a lot of the studies, you have to be careful with that, because a lot of the studies don't really take that into account.
Yes, and we know well that urinary urgency in an older adult, because of the complex interrelationship between falls, cognitive impairment, mobility impairment, and detrusor overactivity, urgency, incontinence, is probably mixed up, and it all is a predestined, if you like, route to geriatric syndromes.
Yes.
And somewhere along that pathway, we may be intervening. It may not increase risk, but you can't tell.
Correct. And I think this has become a hot topic. I think in certain ways it's become overblown, and there have been people who stop writing anticholinergics. I don't think that's the answer. I think we need more research, and I think we just have to use some pragmatic, thoughtful thinking when we approach the patients.
Yes, I think the international consultation frail older adults guidelines, think about burden, what you're trying to achieve, and remaining life expectancy in the light of the small increased association is clearly the way ahead. Clearly, if you want to abolish all risk, at the risk of not effectively treating, you would not use an anticholinergic at all. But there are people for whom other alternative treatments is ineffective, and you need to think about what's available.
Correct. I mean, and the other thought is, and this is beyond the lecture, but I think the days of just trying medicine X, medicine Y, medicine Z, going around and around, I really think we need to move. We have some very good other options beyond medicine. And even in some of these patients, we've done other work looking at patients who have cognitive impairment and how other third-line therapies are effective. I think if you've tried medicine and it's not doing it, you need to consider moving on to other therapies.
Yes, and I see coming from the States there's been quite a powerful opinion piece on why do we have this hierarchical approach given symptom severity, and should we not be blowing through that in light of informed patient choice and preference? And I think that's entirely reasonable.
I would agree. Yeah.
Well, thank you again for a really illuminating dissection of the evidence. I think it was extremely valuable for the audience. And thank you again.
My pleasure. Thank you.